Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Good morning, everyone. Welcome to today's episode of PYA's Healthcare Regulatory Roundup Compliance Webinar Series. Today's topic is Here We Go Again, Medicare Rulemaking in Full Swing. PYA is happy to present today's webinar on this important topic. With that, I would like to introduce our presenters, Martie Ross and Kathy Reep.
Thank you, Jennifer. Good morning, all. Thank you for joining us for 90 minutes of fun. The last episode of Healthcare Regulatory Roundup was back on March 27, and it's amazing to consider how much has happened in a little less than 3 weeks. So we came up with an agenda that is chronological. So we will walk through these developments on a day-by-day basis. We will start with the Medicare Advantage rules, talk about a few developments up on Capitol Hill and the White House, then work our way through the federal fiscal year proposed rules, and wrap up with an executive order issued yesterday regarding drug prices. So without further ado, let's jump into the Plan Year 2026 policy and technical changes to the Medicare Advantage program. So if you remember, shortly after Christmas 2024, the Biden administration released its proposed Plan Year 2026 policy and technical changes rule. And we were eagerly anticipating what the Trump administration would finalize in that rule. Again, just so you are aware of the process we go through, because enrollment starts in early October, you back up from that date to ensure the plans have the information necessary to develop their bids, to submit those bids to CMS, and thus have those bids approved so that they have product to offer in particular counties. So this process always starts at the very end of the year with the publication of the proposed policy and technical changes rule. That rule is to be finalized by April 1st. We were a little bit off. I think it was finalized on, it was released on April 4. But this isn't the dollars. This is all the regulation around how plans interact with providers, what the plan's obligations are, and the like. If you'll recall, in 2024, so Plan Year 2024, the Policy and Technical Changes Rule included several new provisions around prior authorization. So restrictions on when a plan could deny coverage in particular instances. And shortly on the heels of the publication of that final rule, in February of 24, we had some lengthy FAQs published by CMS directed to the plans that provided even more color around those requirements. And we have been urging folks, be sure you've got a copy of that final rule, a copy of those FAQs, because they give you ammunition as you're engaging with MA plans on coverage issues. So let's see what we got in the rule this year. And the best place to start is, what did the plans think? Better Medicare Alliance is the trade association for Medicare Advantage plans, and they were pleased as punch with the rule. And let's see exactly why that was the case. In the rule, there are some new provisions regarding organizational determination. So an organizational determination is anything that a plan does that impacts coverage. So if they say, yes, this is covered, no, that isn't covered, that is a organizational determination. That's a magic term because you have appeal rights that tie to organizational determinations. So what we have in the final rule for Plan Year 2026 is a directive to plans that they cannot deny coverage for lack of medical necessity in 3 instances. If they gave prior authorization, if they issued a pre-service determination of coverage or payment, or if they made a concurrent determination while an individual was receiving an inpatient or outpatient service, absent good cause or reliable evidence of fraud. Again, this was implied, shall we say, in the 2024 rule, but here we have in the 2026 rule some greater specification around this issue of you said yes, and now you're going to say no. CMS also clarified that a plan cannot use clinical information that's obtained after the initial organizational determination to establish good cause to reopen an approved inpatient admission. Of course, leaving open the question, can they use such evidence in other circumstances to reopen a determination? But we at least know for inpatient hospital admissions that will be the case. And then a clarification that a plan must notify an enrollee and the provider that sought an organizational determination of the decision that it made. So if you, on behalf of a beneficiary, reach out to the plan to get prior auth for a procedure, it's incumbent on the plan to notify both you as well as the beneficiary on whose behalf you sought that prior authorization that they have in fact made a determination within a specified period of time, and that you in fact have appeal rights if you failed to receive such notice. So if you requested a PA, you never received notification back from the plan, you went ahead and provided the service, the plan comes back and says, well, no, we issued an organizational determination denying that coverage. That in and of itself, the failure to actually provide you with a copy of it is now appealable. Other provisions in the final rule.
On that, I think one thing we need to be very careful about is how we're tracking those organizational determinations coming back into the facility, and that they are properly identified and recognized, so that we don't provide the service not recognizing that we got a denial.
Exactly. Other provisions in the final rule addressed special supplemental benefits for the chronically ill. So this is not the standard benefits that you see in MA plans like dental, vision, hearing aids. These are additional benefits that are offered to certain categories of patients to address their health needs. Typically individuals with complex chronic conditions, and the benefits that are offered can include non-health related items, such as housing repair or transportation or the like. Most special supplemental benefits are offered by special needs plans. About half of the special needs plans include these special supplemental benefits, particularly those special need plans based on chronic condition. Only a very small percentage of other MA plans, about 15%, offer these benefits. But interestingly, in the proposed rule, the Biden administration said we want to detail out specific types of supplemental benefits for which we've received requests for approval that we've determined, in fact, do not qualify because they would not, in fact, in any instance, improve or maintain health or function of the individual's health or their health functions. So they detailed out what those first 1, 2, 3, 4, 5, 6 bullets in the proposed rule and said these will never be approved as a special supplemental benefit. Interestingly, the Trump administration added one to the list: non-healthy food.
Please define that.
Yeah, exactly. There is no definition for non-healthy food. And this is really interesting because right now what you have going on in the SNAP program, formerly known as food stamps, several states have now been requesting to the Department of Agriculture that they limit their SNAP benefit to exclude candy and junk food. So it's certainly going to be an area of interest, but it's just interesting that they called that specifically out without definition here in the final rule. Also, some provisions in the final rule regarding special needs plans to avoid specifically dual eligible special needs plans, individuals that are concurrently enrolled in Medicare and Medicaid, trying to streamline the processes so that you're not serving two masters, shall we say, and certain requirements within the state Medicaid plan, certain requirements within the Medicare program, trying to streamline those for individuals in those plans. That's it. That's the final rule. So what's not in the final rule that was in the proposed rule? There were several provisions that enhanced, there were several provisions in the proposed rule, that were enhancements to those provisions in the 2024 rule regarding internal coverage criteria. So when is a plan able to write its own rules regarding coverage versus when they have to follow what Medicare CMS has promulgated within traditional Medicare. The prohibition on plans imposing in-network cost sharing for behavioral health services that are greater than the cost sharing in traditional Medicare. I think interesting discussion in the proposed rule that one of the reasons seniors like MA is because they see it as lower cost sharing obligations. But there were many plans, enough that it drove the attention of CMS to include it in the proposed rule, where in fact the cost sharing for behavioral health services was greater for those in MA plans, but that was not finalized. Provisions in the proposed rule regarding changes to star rating measures, these were not finalized, so we will continue on the same star measure ratings going forward. Requirements on brokers and agents that are selling MA plans to seniors. There were proposed additional disclosure requirements that if you're a broker or an agent talking to a senior about an MA plan, you needed to provide certain additional disclosures. There were two. One was potential eligibility for the low-income subsidy and the Medicare Savings Program. And the second was explaining to seniors that if they enroll in MA now and later choose to return to traditional Medicare, that they are not guaranteed issue under Medigap policies. And in fact, in many instances, individuals that spend 2, 3, 4, 5 years in an MA plan want to go back to traditional. They find out it's cost prohibitive because the premium for the Medigap plan under traditional Medicare is skyrocketed because it's now taking into consideration they're older, they have more diagnoses, a higher risk, and all of that. One area where we still have medical underwriting is in Medigap plans, one of the few places. And so the idea was we would brokers would be disclosing that to beneficiaries, but CMS did not finalize that requirement. More things not in the final rule, requiring plans and other third-party marketing organizations to submit what are called generic MA ads for review and approval before use. So there is one of the requirements I think imposed back in 2023, right? That's when the rule went into effect, is there's now a prior approval process within CMS that if you are marketing your Humana plan or your United plan or your Blue Cross plan, and you specifically call out the name of the plan in the advertisement, you have to submit that to CMS for approval to ensure that it's not misleading for consumers. And as they said in the proposed rule, since 2023, CMS has denied over 1,500 TV ad submissions because they were misleading to consumers. Well, in the proposed rule, CMS had wanted to close the loop and say, well, additionally, if you have generic ads that just say Medicare Advantage is great, those should also be submitted for review, but that was not finalized this year. Requiring plans to provide and regularly update provider directory data so that CMS can then load that into the Medicare Plan Finder. That's what most seniors use, the Plan Finder, to identify, I can go to this speaker, I can go to this provider, right, because they're on my list. But that wasn't finalized, so we continue to have what often is out-of-date information in the Medicare Plan Finder. And also there were clarifications of specific expenses that would be excluded or from inclusion in the medical cost ratio. So remember, 85% of the dollar has to be spent on healthcare provision or ensuring the quality of the healthcare, and the other 15% is administrative costs and profit. And so if you're a plan, right, you want to put as much stuff as possible down in that 85% to give you more room, shall we say, in the 15%. And this was a provision in the proposed rule that would have provided some clarification on certain types of expenses that they would have to be on the 15%, not the 85%. That was not finalized. Still more things that were in the proposed rule that didn't end up in the final rule, specifically around health equity. What CMS did not finalize were proposed guardrails on the use of artificial intelligence in making organizational determinations. CMS did note that they have broad interest in the regulation of AI, but were not willing to specifically create guardrails within the MA program relating to its use. There were new reporting requirements that had been proposed relating to the annual health equity assessment of utilization and management policies. Again, back in 2024, CMS said, okay, on an annual basis plans, you need to look at your utilization policies and ensure it's not having improper impact on certain groups of the population. There were some reporting requirements that had been proposed around that. CMS did not finalize those. There were also some changes, modifications to the health equity index reward that is to be included in the star rating starting in 2026. CMS did not finalize those. Instead, what we received from CMS is a notification that they were reviewing several elements of Medicare Advantage for consistency with Executive Order 14192, which is the Unleashing Prosperity Through Deregulation Order. We'll talk more about that in a few minutes. That includes the renaming the Health Equity Index Reward to the Excellent Health Outcomes for All. And they will begin implementing that in 2027. This whole idea of doing the assessment of utilization management policies, they said that potentially may go away. Requiring MA plans to provide culturally and linguistically appropriate services, and quality improvement in health risk assessments focused on equity and social determinants of health. This is going to be a theme we're going to come back to again and again. Striking these provisions within the Medicare regulations that relate to health equity as well as social determinants of health. So it's interesting, in the final rule, they didn't go beyond what was in the proposed rule. They stayed in their lane and didn't add other regulations, but they did put us on notice that these are areas that they are considering for subsequent rulemaking to remove those requirements from the plans.
But overall, Martie, wouldn't you say that the protections that we thought we were going to get in a final rule for both providers and the beneficiaries kind of left on the table?
Yeah, I think that pretty much explains why Better Medicare Alliance was happy with this proposed rule. With this final rule, excuse me. Okay, so that gets us then to the Plan Year 2026 MA rate announcement. This actually isn't a regulation. It's not published in the Federal Register. It's just released on the CMS website. It came out on April 7, so a week ago Monday. And so this is the document that tells MA plans how CMS is going to set the benchmark. And the benchmark is then what's used to calculate plan bids, which then determine how much the government pays an individual MA plan for beneficiaries it provides coverage for. So to understand what happened in the rate announcement, you kind of back up and understand how MA capitation payment rates are calculated. So remember, the core of an MA plan is, rather than CMS directly paying for services provided to a beneficiary, CMS instead pays a capitated amount to an MA plan. And the MA plan then uses that payment to pay claims and otherwise cover administrative costs, leave some for profit. So how are these capitation rates calculated? And we start with a standard benchmark. So we use last year's benchmark. And we calculate what's referred to as the effective growth rate. That is the projected increase in traditional Medicare per capita spending for the upcoming plan year, not MA spending. We actually use projected increases in traditional Medicare spending to calculate the benchmark used for Medicare Advantage. Okay, that's utilization. Effectively, the effective growth rate is, do we anticipate utilization of services going up on a per capita basis? Of course, we expect overall because the Medicare population is growing. But this is all measured at a per capita level. And the effective growth rate is telling you how much more will it cost per head in the traditional Medicare program. So we're going to look at enrollment trends. We're going to look at utilization, changes in payment policy as well. But really the driver there is utilization. So we start with old rate, apply the effective growth rate, and then we do county adjustments, okay? Because there's some counties that have lower costs. So we're going to multiply the benchmark by 1.15, so 15% higher than the benchmark for those counties, right? Those counties that have higher costs, we're going to take the benchmark and multiply it by 0.95. Now, if you look at these percentages, right, 1.15, 1.075, just per capita costs, 1.95, it's inevitable that the county adjustment is going to end up higher than the standard benchmark. Okay, and then finally, to calculate a plan's standard benchmark, we apply the quality bonuses that are generated off the star rating. So if you have a plan that has 4 or 5 stars, they get a 5% increase in their benchmark. And for plans that have that cover counties that are low costs in that one quartile, that top quartile one, they actually get a double bonus. So it's 10% above the county benchmark for those individuals. So that gets you to the standard benchmark, okay, for that county. Then you go to the risk-adjusted benchmark, and this is specific to each plan. That's where their plan risk score comes into play. So this is based on enrollee demographics, sex and age, and then their HCC score. So all of those diagnosis codes that create a risk profile for an individual reflected in the hierarchical condition categories. And then by statute, CMS cannot, they must lower the risk scores by 5.9%, at least 5.9% to account for any coding intensity. So the fact that MA plans encourage providers to add more diagnoses, appreciating that that results in higher HCC scores in the MA population versus the traditional Medicare population, CMS says we're going to automatically cut a minimum of 5.9% off the risk score to account for that coding intensity. So once you have the score, once you have the benchmark, plans make bids. That's what they're doing right now. They're starting in the process of making bids. They have to submit them to CMS. If a plan's bid for a county comes back at above the risk-adjusted benchmark, CMS is only going to pay that plan the risk-adjusted benchmark. If a plan's bid is below the benchmark, CMS is going to pay the plan its bid amount plus a rebate. The rebate is between 50 or 70% of the difference between the bid and the rebate, the bid and the benchmark. And it depends on your star rating. So if you have a 5-star plan, they're going to get 70% of rebate. You know, lower stars are going to get only 50% of the rebate. The hitch is that rebates have to be used by the plans to provide additional services or lower enrollee costs. So this is how plans get to zero premium, no lower copays, and they offer things like dental and vision and Fitbits and all of those things. And that's in part what drives what we refer to as favorable selection in MA, meaning that healthy people, because they like all those extra benefits and they're willing to take a risk, will enroll in an MA plan with a limited, network of providers. That's favorable selection. MedPAC, in their March 2025 report to Congress, we'll come back to that, said that rebates will in 2025 account for 17% of all payments made to MA plans. So it's growing in terms of the dollars that are going to MA plans to offer those favorable extra supplemental benefits that attract plans to MA.
And that's why whenever the star ratings are published, the plans are so aggressive in terms of even challenging the calculation of their star ratings, because again, we were looking from 50 to 70% in terms of potential rebates. If your star ratings are low, then your rebate's going down, and they're very concerned about keeping as many dollars as they can. So Martie mentioned the Medicare Payment Advisory Commission, their March report to Congress. They did have a detailed section, I think the longest section in their report this year, related to Medicare Advantage. We have to do a little bit of history and go back to the fact that when the Medicare Advantage or Medicare Plus Choice or Medicare Managed Care, however we want to define it, going back in terms over the years, Medicare Part C, when the program was established, they were essentially setting an expectation of payment going to the plans to be equal to 95% of what traditional Medicare or fee-for-service Medicare would be receiving. What we are now looking at, based upon the most recent MedPAC report, is that on average, the benchmarks are providing payment to the plans of about 109% of Medicare fee-for-service. So rather than 95%, we're at 109. There are things, the MedPAC has essentially attributed these higher costs to two things. One is favorable selection, and the other one is coding intensity or the risk scores. Coding and favorable selection essentially is expected to increase the payments by about 11% over what would have been received for traditional Medicare, fee-for-service Medicare. The coding intensity adjustments is about 16% higher, as opposed to that statutory minimum that Martie mentioned of 5.9%. So again, increasing the payments to the plans other than over what would be provided for fee-for-service beneficiaries. Impact of all of this is the impact. We've got to look at the impact on Medicare Part B, because this is for those enrollees who are in a managed care plan and they're required to have Part B, as well as those individuals who stay in traditional Medicare who have Medicare Part B. Essentially what has happened is that we're looking at overall premium payments for Part B being increased by about $13 billion because of the MA payments to the plans. So we're looking at about $198 a year per beneficiary impact of the overall payments to the MA plan under their Part B premiums.
So that was a long way to get to what happened on April 7th, which was the 2026 rate announcement, where CMS projected a 5.06 increase in payments to MA plans for plan year 2026. Compare that to what had been in what's referred to as the advance notice that's published in early January. At that point in time, they had projected only a 2.23% increase. What happened? How did this end up going up almost 3%? That increase is attributable to what we talked about earlier, the effective growth rate. CMS said additional data became available, and following the statutory formula, the effective growth rate went from 5.93 up to 9.04. And specifically, CMS called out, it was the Q4 2024 utilization data. So you saw a significant spike in utilization in that quarter, which changes the effective growth rate. Again, how much we spend on Medicare, traditional Medicare beneficiaries, and that results in higher payments to the MA plans. CMS did temper the news by noting, that three important developments. One is what's the application of the statutory coding intensity adjustment. 5.9% is the floor, right? And CMS has always used the floor. It has never gone above that authority, even though MedPAC is telling them it's accounting for a 16% difference. So we've got a 10% gap that's not being addressed when CMS publishes the rate. The good news, I guess, for what it's worth, there were two technical changes that CMS had implemented over a 3-year period. One was to account for direct and indirect medical education costs. The other was changing HCC risk models and implementing a new formula to calculate those risk scores. CMS did go forward in finalizing full implementation of those two models. If they had not, the increase would have been even more than we saw in the 5.5% rate. So, of course, whenever the rates go up, we've got winners and losers. As referenced previously, 5.1 is the highest increase we've seen for MA plans over the years. But these are the reports for the major insurers. This is the stock reports for the major insurers the day after the rate announcement was made, which, if you remember what was going on in the stock market on April 8th, even with all those pressures, the health insurance markets still saw their values soar as a result of these increase in payments. So they basically assume that these plans are going to be making a greater profit that will equal greater distributions to their shareholders. That gets us to polling question number 1. So back to you, Jennifer.
All right, our first question is, do you think it is more likely that Congress will reduce Medicare payments to providers or payments to Medicare Advantage plans? 1, more likely to cut provider payments. 2, more likely to cut Medicare Advantage plan payments. 3, equally likely Congress will cut both. Or 4, equally likely Congress will cut neither. You must fill out the polling questions in order to receive CPE credit. You will have 30 seconds to answer.
So, Kathy, if we had been exact in our wording, I think we would have said, instead of cut, we would have said not increase as much because we never really cut payments. We just don't increase them to correspond to the increase in the size of the population. So, for what it's worth.
Okay, I'm fascinated by the results here.
Yeah. Give you all a few more minutes. Remember, if you want CPE for your attendance today, you do have to complete the poll. The machine knows you have to complete all 5 of the questions, and then it will give you that CPE certificate.
Thank you for participating in our poll. Now back to Martie and Kathy.
Well, you're optimistic.
Yeah. Well, actually, I want to say they're optimistic or they're pretty negative in terms of we're going to cut everything. Yeah. So
we shall see.
All right. Now
we had April 4, April 7. Now we're up to April 9th. Kathy, what happened?
We received a presidential memorandum addressing the appeal of unlawful regulations. So
Kathy, that's a typo. That's a typo. Go back. How all of us looked at that. It should be directing the repeal of unlawful.
Oh, I'm sorry.
All of us looked at it. Yeah, sorry about that, everyone.
Yes. Okay, so we've got it correct here on the repeal process. Essentially, what we're looking at an executive order that came out back in February that was then followed by this April 9th memorandum. The executive order essentially required the various departments and agencies within the federal government to identify any unlawful or potentially unlawful regulations by April 19th and begin plans to repeal them. And then in the April 9th memorandum said that beginning April 19th, which is Saturday.
Mm-hmm.
All right. The agencies are essentially going to be required to take steps to move forward to begin the repeal process for any regulation or portion thereof that exceeds their statutory authority. And then by May 19th, the agencies must submit a written explanation as to why they did not follow the executive order and the April 9th memorandum. Martie, just thinking about this, we had the notice related to, I believe it came out from CMS or HHS. I guess HHS came out after April 9th that addressed the issue in the, I'm trying to remember. It related to gender.
Oh yeah, the order, the clarification on the
what was in the preamble
on gender dysphoria as a disability. Yeah.
What was included in the preamble was not to be considered regulation. and was not a part of the final regulation. And even though it was addressed in the preamble, so I think that was the first attempt at following through on this process.
Yeah, so
the
wait a
first
moment,
one
Kathy. We did the Chevron webinar last July or August, right? So what's the impact of Loper Bright, which was the end of the Chevron doctrine? And here it is, right? This is the directive from the president to the agencies. Find all those regulations that you think go beyond the statutory language, that are not based on the best interpretation of the statutory language, and repeal them. And no notice or comment. No notice or comment, because they're relying on the good cause exception. And since it's unconstitutional because it goes beyond the statutory language, you aren't obligated to provide the opportunity for notice and comment.
But there will be, I guess, some way or other, we've got to see a notice that this has been repealed.
It's been repealed. So, I mean, Kathy and I are like, okay.
No opportunity for comment.
So I'm thinking the Federal Register for April 21st, right, Monday, is going to be like this, right? It's going to be all these notices coming from the agency saying this has been repealed and this has been repealed and that has been repealed. But this one hasn't got a lot of attention. But wow, we'll see how far the agencies go. And in the memorandum, they list 10 Supreme Court decisions in the last several years, and say if any of your regulations are not consistent with the Supreme Court's decision in these cases, then we have to repeal them because they're unconstitutional. And we just do it by telling you we're doing it, and that's it. So I think maybe there'll be some litigation. What do you say, Kathy?
I think definitely there will be litigation.
So on this note, just a little preview of our next healthcare regulatory roundup at the end of the month. We're calling it Deregulation O-Rama. And we'll address during that webinar what we see coming out of the agencies in response to the April 9 memorandum, as well as some additional deregulation activity we're going to talk about in just a bit.
All right. That will make things fun on April.
That will. Okay, let's do another polling question, Jennifer.
Our second question is, what should be the top target for deregulation of healthcare providers? Conditions of participation, quality reporting requirements, beneficiary notice requirements, HIPAA privacy and security rules, non-discrimination rules, or other. You must fill out the polling questions in order to receive CPE credit. You'll have 30 seconds to answer.
Not to influence your answer or anything, but Kathy and I hate beneficiary notice requirements.
Absolutely. Absolutely.
There's no reason to post a notice of privacy practices. It's on your website. We give it to them.
You give it to them and have them sign it. So
exactly. So you don't need to post it. Oh, well, sorry.
But didn't you have a comment to make about Michael's and that particular?
Well, right. You have to go get them framed, right? So they can hang on the wall. So the only party interested in maintaining the notice posting at the facility requirements is Michael's, because they do all the framing for the hospitals on that and all the providers. But
we'll interesting. See. And they
see, we influenced it. They're all saying notice requirements.
Thank you for participating in our poll. Now back to Martie and Kathy.
I just wish under other we had them some way or other tell us what other was. I'd love to know.
Well, the technology is not fancy enough, but they can put it in the chat or drop us a question if you've got other ideas. Okay, budget reconciliation process. This gets us up to April 10th. What happened and where are we today? So remember, the budget reconciliation process is setting 10-year targets for mandatory spending. So appropriations is non-mandatory spending. And reconciliation is mandatory spending. Medicare, Medicaid, Social Security, SNAP, all of that falls in the pile of mandatory spending. We have to start this budget reconciliation process with a budget resolution, which directs the House and Senate committees to develop proposals on specific how to increase revenue or how to cut spending. And then the committees are then responsible for drafting that implementing legislation. Why reconciliation is so critical? Because filibuster rules do not apply in the Senate. meaning you can pass legislation, you can pass a reconciliation bill through the Senate with 50 votes, right? Because the vice president breaks the tie. So this is your opportunity to put all of your priorities within this one piece of legislation and avoid the 60 vote requirement in the Senate. That's the big to do. And we've been talking about this one big, beautiful bill, as President Trump described it, which would have both the renewal of the 2017 tax cuts, additional tax cuts that were promised during the election, plus increases in defense spending, energy spending, and immigration enforcement. That was sort of the whole scope of this big, beautiful bill. So where are we on that? So back on February 21, Senate passed its budget resolution, didn't address tax cuts, said we'll do that in a separate bill. House passed its resolution 4 days later. They said, you bet we're going to address tax cuts. We want to include tax cuts, and we're going to authorize $2.3 trillion to increase the deficit to pay for the tax cuts. We'll offset that with an additional $1.5 trillion in mandatory spending cuts. Okay, so the amount you're going to increase the deficit plus the spending cuts gets you to the amount that we want for tax cuts. Okay. So the Senate then on April 5th passed an amended budget resolution. So it sort of took its resolution and the House resolution and kind of wove them together. It calls for increasing deficit spending by $2 trillion. Why is that lower? Because the Senate used something called current policy, meaning that even though the tax cuts are expiring, we're not going to count the cost of extending them. So we're just going to assume that they continue in perpetuity and they don't have an effect on the deficit. If you don't account for that, the Senate bill is going to increase, the increase in the deficit would be closer to $5.7 trillion. Interestingly, this Senate resolution says the House committee, they're in charge of finding $1.7 trillion in mandatory spending cuts. And if they don't find it, we're going to reduce the amount of the tax cut accordingly. The Senate committees are charged with finding $4 billion in tax cuts. See, a little bit of a disparity there, right? The House is talking about trillions, and the Senate's talking about a few billion. The House finally voted last Thursday to adopt the Senate resolution. So we finally have an approved budget resolution, meaning that we now move into the phase of approving, developing the big, beautiful bill and going forward. So what happened?
Specifics of what's going to be cut, or
yeah, right,
or
they're going to propose
tax provisions.
Yep. So Wednesday night was the original scheduled vote in the House. Speaker Johnson called off the vote, and the next morning he appeared with Majority Leader Thune, where the Senate triple promised that they would cut $1.5 trillion in spending, because there were a bunch of House members that said the Senate is never going to go with any cuts. We're all about cuts. We don't want to pass the Senate bill because we're not getting what we want, which is reductions in spending. So that's why Thune had to stand up and double promise that, in fact, the Senate was ready to move forward with spending reductions, but while preserving essential programs. Okay. So work starts in earnest on April 18th because of course, they pass the budget resolution and go on a 2-week vacation.
April 28th.
April 28th, excuse me.
Because they're out for 2 weeks. They're out for 2 weeks,
right? And then the resolution calls on the committees to submit their recommendations by May 9. That's not binding, but that's the target. Of course, the issue that's capturing all the attention right now is that this resolution includes the directive to House Energy and Commerce to cut $880 billion. The only way they can get there is some sort of cuts to Medicaid. So what's going to happen there? And then even $800 billion is less than $1.5 trillion. So there are other things that will have to be cut. And that's why we're really looking at Medicare provider payments, because no one thinks we're going to see cuts in Social Security. And if you look at the three big buckets of mandatory spending, those are your options: Social Security, Medicare, and Medicaid. What happened this morning was a report that, and this didn't even make the slide, but there was a report that there were 12 House Republicans that sent a letter to the Speaker saying, we will in no way, shape, or form vote for a bill that includes cuts to Medicare coverage.
Medicaid.
cuts to Medicaid coverage. That letter goes on and says, but we understand that there's opportunities with fraud and abuse and the like. And so they're still very open to cutting provider payments under Medicaid. And remember, no direct spending by the federal government on Medicaid, right? Because it's payments made to the states, and the states administer the Medicaid program. So what we're talking about is how much the federal government's going to reduce its payments to the states, and then what did the states do in response to that? So shall we say, stay tuned. Things are going to start getting really interesting at the end of this month. Only question number 3, please, Jennifer.
All right. Our third question is, where will Congress find the $1.5 trillion in mandatory spending cuts? Cuts in Medicaid payments to states, plus cuts in Medicare provider payments, plus other cuts? Cuts in Medicaid payments to states, plus other cuts? Or other cuts, no Medicare or Medicaid cuts? You must fill out your polling questions in order to receive CPE credit. You will have 30 seconds to answer.
And just to clarify, when we say cuts, we're referring both to reductions in coverage and reductions in provider spending, provider payments. That's kind of what's on the table.
Thank you for participating in our poll. Now back to Martie and Kathy.
All I can say is right answer.
Yeah, exactly. I think we're all preparing for reductions in spending in the federal healthcare programs. Okay, finally, we have made our way to April 11, which is last Friday, and that is when
last Friday at 4 o'clock.
At 4 o'clock, yeah, 3 o'clock my time, right? So it wasn't as bad. But
so
CMS
than I have.
Yeah, I've had last time. But CMS dropped all of the federal fiscal year proposed payment rules. So that's inpatient hospital, skilled nursing facilities, inpatient rehab, inpatient psych, and hospice. So there are 5 of them. So let's walk through the key provisions of this. Because the rules were released on April 11, that means comments are due on June 10. And there are many fun things to comment on, beginning with, shall we say, Kathy, the RFI.
And the RFI, one thing I want to make very clear is we're talking about commenting on the proposed rule, which you are going to submit comments through the Federal Register on the proposed rule. But this particular RFI, you have to submit comments on a little bit differently. And this is one thing that we're going to be spending some time on when we have our April 30th webinar, the deregulation ORAMA. I just want to say a different term than the ORAMA. But in the inpatient rule, the psych rule, skilled nursing, and rehab, they all included a provision, and this was in response to that executive order that related to deregulation that Martie talked about earlier. And what CMS has said is that they are seeking public input. Previous discussion was on the agencies themselves providing, moving forward with deregulation, but they are now seeking public input on various opportunities to streamline regulations, reduce administrative burden. What opportunities are there to reduce administrative burden? Did we just say something about all of the patient notices that we have to do? Duplicative requirements. But as a provider, whether you are in the hospital or the physician setting or any type of provider, you recognize the administrative burden that is tied to the overall registration, billing, etc. process. And we would love for you to think about commenting on this and also share with us your thoughts in terms of what can be eliminated. I don't know how many of you have had to deal with the the MCSN, the Medicare Change of Status Notice that was effective on Valentine's Day. And if this is something that you feel is truly needed for patients or could be administered a different way and perhaps not by the provider themselves. So think about it and do consider commenting on this request for information.
I think it's interesting to note, Kathy, that the June 10 deadline leaves them plenty of time to include any of that in the calendar year payment rules, right? So they have hospital outpatient, Medicare physician fee schedule. So this could go very quickly.
Yes. And recognize that what we're probably going to see, because of the requirement that came about through the new administration, that for every new rule, that there needs to be rules eliminated. Therefore, we're going to
10.
So rather than publishing a rule that addresses the MCSN or that addresses the moon or anything else, they're all going to be rolled into one rule. And it's very likely that we will see things in unrelated rules, so that we're going to see under the physician rule, we could see things related to hospital requirements. The same thing for the OPPS rule. We're going to see final rules, or very likely see final rules related to deregulation of certain provisions. Mm-hmm. So let's talk about what was actually, okay. All right, what was included in the inpatient rule as far as payment goes? And I literally this morning, I was doing some calculations. Last year, I believe it was, we had an issue related to the final rule, basically with the comment of when is a 2.9% increase, not a 2.9% increase, because the math did not follow through. We're going to kind of see that again in a minute. But first of all, CMS is moving forward with using more current base year data. They're going to use 2023 as the base year to calculate both the capital and the operating market basket. They have indicated that the market basket, based upon using the new year, the overall increase in cost was 3.2%, but they are adjusting by 0.8% for productivity. And they have proposed a 2.4% increase in your base rate. Last year, our final rate was 2.9%. We're going to talk about this in a second. Another provision for those hospitals with a wage index greater than 1, you currently have a labor portion of your base rate of 67.6%. They are proposing to reduce this to 66%. For hospitals with a wage index equal to or less than 1, you stay at 62% because that is mandated under legislation. But if we're going from 67.6 down to 66%, what you're going to see is less of your overall payment rate will be adjusted by your wage index, and you are the hospitals with the higher wage index. So you actually want more of the base rate adjusted by labor. In this case, they are proposing to reduce it. So take a look at that and the impact on your organization. Capital is projected to go up about $18 to $528.95. They are proposing to decrease the IPPS outlier threshold. That essentially means it should be easier for a claim to become an outlier, but not by much. We're just going to kind of see what happens with the overall uncompensated care pool, because they have proposed an increase in the pool of $1.4 billion. Questioning what will happen in a final rule, because in the past we have seen proposals for increases that we did not get in the the uncompensated care pool. And there is an increase of $234 million included for new technology. Now, let's take a minute and look at the numbers. This is the table that was posted on the CMS website in mid-March. It's the most recent table that they have posted. They did not include the rate tables in the rule that has been posted on this Federal Register website. But if I look merely under Table 1A and I look at a labor rate of $45.11.41 plus a non-labor related rate of $23.24.06, I get a total payment of $68.35.47. $6,835.47. Compare that to our current rate of $6,606.51. And somebody is going to recognize this. Wait, that is not a 2.4% increase in our rate. That is actually a 3.5% increase in your rate. Where did this come from? So when they have said we are increasing the rates by 2.4%, but they have published a rate of 3.5% higher, I have a feeling that we might see an adjustment or a revision published, maybe even with the actual paper copy of the final rule, because I think the dollars are off.
Paper copy of the proposed rule, right?
A paper copy of the proposed rule.
Yeah.
They're either that or they're going to have to publish a updated proposed rule some way or other. So.
And you do this math every year, don't you, Kathy?
Well, after some friends at a hospital in Georgia called to our attention, I'm not getting 2.9. We started doing some investigation and 2.9 is not 2.9. So now we're dealing with 2.4 is not 2.4.
Yeah. I mean, the lesson here is if you're doing some projections using these tables, an ounce of caution. I mean,
yes,
some caution.
I would be very about using the dollars. I would go back to the 2025 rate and increase it by 2.4%. And I could be wrong in this. I'm anxious to hear what people have to say. So with that, we got a polling question.
Our fourth question is, what's your reaction to the proposed 2.4 increase in the base rate? It should be less. Hospitals don't need the extra money. Happy to have it. The increase should be somewhere between 2.5 and 5%. Hospitals should receive the same increase as Medicare Advantage plans, 5.06%, or hospitals need more than a 5.06% increase. You must fill out the polling questions in order to receive CPE credit. You will have 30 seconds to answer.
Yeah, Kathy, we always see lots of comments, people on the rate adjustment, but the issue is CMS is just doing the math because right. the formula is in the statute and they have to use this data and you get that number. So complaining to CMS, unless they have messed up the math that you just referenced, their hands are tied because it's the legislation that dictates what that percentage increase is going to be. Just like for MA plans, it's that driver of the effective growth rate that increases their payment rates. We don't adjust in that way. And as you'll note in a minute, mistakes made in prior years. So if they underestimated the impact of inflation in prior years, it becomes cumulative because that's the rate we start from for the next year.
And one thing I wanted to mention, Martie, is that we have a comment in the chat related to the uncompensated care pool and the fact that the increase that is proposed is tied to the sunset of the ACA exchange subsidies. But if the question is, will that happen? So this was where we could see some real changes in the final rule.
Will that happen in terms of
money? Don't spend that money.
You mean the extension of the subsidies for the ACA pool?
If they're assuming that it goes away.
Yeah, I'm about 100% certain that's going to happen.
We're going to see. We'll
see. We'll see. Right. Right. We're glad that a lot of you are as snarky as we are, saying that we should get the same raise that the MA plans get.
And I love those who said that you're happy to have it, but all right. The low wage index hospital policy, these were for the hospitals in the bottom quartile of the wage index. And for a few years, CMS provided those hospitals a boost in their area wage index. And they paid for this in a budget neutral manner by lowering the base rate for all hospitals. Through a number of court challenges and litigation, CMS has officially now saying that they are discontinuing the low wage index hospital policy for fiscal year 2026 and beyond. However, I am adopting a policy where I am discontinuing the policy, but I am going to do a exception policy, a very narrow, as they have stated, exceptions policy. This will be budget neutral. Therefore, it means that other hospitals will be seeing an adjustment to their base rate based upon those hospitals who qualify for the exception policy. They are going to be looking at those hospitals who qualified for the low wage index adjustment in 2024. If their proposed 2026 wage index is going to decrease by more than 9.75% from their 24 index, they will be paid as if their 2026 wage index is equal to 90.25% of the wage index that they had in 2024. So the policy that's going away is going away for the majority of the low wage hospitals, but those who've had a significant change in 2026 compared to 2024, CMS is still going to be making an exception for those providers.
I think it's still subject to litigation. I mean, it's the same issue.
It's the same issue. And so we're going to see if people are going to comment or if they're going to take it further.
Right. Or will the haves really go after the truly have-nots, shall we say, in challenging that policy? Okay.
This is another interesting provision in this rule. I think I almost think CMS might be better off if they were silent on this, but here goes. This is calculating the pass-through payment for nursing and allied health. They have proposed this change because of litigation in the Mercy Health St. Vincent Medical Center case against a CMS Administrator Becerra. Okay, HHS Secretary Becerra. Here's the current formula according to the regulations. To calculate the pass-through payment, you look at your total costs, which means your direct and your indirect costs. And that got changed, plus tuition, I believe it's a minus two, yeah. Plus tuition minus equals your net costs. Okay, your proposed formula is direct costs equal your tuition. Sorry, the slide got changed and I didn't catch it. Direct costs minus tuition plus indirect costs. So those colons should be minuses, all right? So total costs, which are direct and indirect, minus tuition equals net, and then direct costs minus tuition plus indirect costs equal net. What happens here by changing this formula in regulation is that it impacts your allocation of your administrative and general costs because it reduces the amount of direct costs that have dollars allocated to them from other across the hospital. Problem is your current cost report instructions match the proposed formula, which is direct costs minus tuition plus indirect. So it's interesting the way this is going to work. Again, it's not really going to change anything because it's the way the cost report works. This might be one of those things CMS would have been better off being silent on, and I do apologize that the slides got changed midstream. Included in the inpatient rule, I'm sorry, I missed one. There was also the provision related to long-term acute care hospitals. That was included in the inpatient rule. Usually the two are published together. We are looking at a 2.6% increase to the long-term care PPS payment rate. That's the same rate that they got in 2025, same rate increase. They are looking at an outlier threshold for long-term acute care hospitals of $91,000. That's almost a $15,000 increase over where you are now. So recognize that the concern in terms of the reaching an outlier claim as if they adopt this moving forward. And then there was also a request for information included in the inpatient rule related to digital quality measurements and using the fire standards, or the HL Health Level 7, HL7 Fast Health Interoperability resources, and whether or not we should move forward to this new electronic clinical quality measure reporting in using the fire standards moving forward. They've asked for providers to comment. They've also asked from an inpatient psych facility perspective whether or not this should be the new methodology for reporting patient assessments. Martie?
If you've ever wondered why the inpatient rule is always so long, it's because it's the vehicle through which CMS also makes adjustments to the quality reporting program, the promoting interoperability program, as well as the value-based purchasing programs, and lots of changes in store this year for all of those, starting with IQR. Remember, if you don't report your inpatient quality in a timely manner, Kathy, they adjust your market basket by 0.5, 0.25?
Yes.
Right. Okay. So this is report or lose part of your market basket update, i.e. your payments go down. So they are modifying 4 current measures. For 2 of those measures, they intend to add to the cohort of patients, so increasing the denominator, by adding Medicare Advantage patients. So these are 2 measures. One is the complication rate following hip and knee replacement. The other is the mortality following ischemic stroke hospitalization. For those 2 measures, historically, the denominator has always been only Medicare patients. They now intend to add Medicare Advantage patients, saying that's more indicative of the population. They also intend to change the measurement period for these 2 measures from 3 years to 2 years, saying that that denominator will be of sufficient size in 2 years with the inclusion of the MA population. For 2 other measures, the hybrid hospital-wide readmission rate and the all-cause standardized mortality rate, CMS is proposing some modifications on the reporting requirements. Note that those would be effective beginning of July. So if you are folks responsible for that data, certainly pay attention to that proposal. Other changes to the IQR include removal of the COVID-19 diagnosed patient measured denominator exclusion beginning in 2027. So these were adjustments made during COVID to remove patients from the denominator if they had been diagnosed with COVID. So trying to make sure you keep an even population despite the pandemic. CMS says COVID's over. We looked at the data. There's no reason to continue making those exclusions going forward. CMS is removing 4 existing measures from the 2026 payment determination, which are the hospital commitment to health equity, screening for social drivers, screening positive rate for social drivers, and the COVID-19 vaccination coverage for healthcare personnel. What's interesting is that this is the adjustment being made for 2026 payment determination, which is based on 2024 performance. So even though you reported on these measures, we're throwing it out. We're not going to consider that when we're calculating your IQR.
And what's really interesting is providers or I want to maybe say sad, is that providers have put so much focus on making sure that they are doing the screening, that there is a commitment to health equity. They've put resources into this. And can you really eliminate it? No, you can't, but it's not going to be considered a measure.
The explanation in the proposed rules that it's unnecessary administrative burden for hospitals to compile and report on the data. It does not comment on the actual activity of collecting that SDOH data. Okay, and again, you're going to see this across all of the proposed rules. CMS updating its extraordinary circumstances exception, where a provider can say, "I've been subject to a hurricane, a tornado, a whatever, and I'm not able to report." CMS has previously waived its authority under the regulations has been to waive participation for that year. CMS is saying now we're going to have the option of simply delaying data submission. You'll still have to, once the extraordinary circumstance is over, you'll have a period of time in which to collect the data and then submit it. Not necessarily that they'll always do that, but they want to have that option going forward. On the Promoting Interoperability program, and if you fail to report on Promoting Interoperability, Kathy, your penalty is?
I
I should have told you there was going to be a quiz.
know. 0.8?
Yeah, it's higher. It's higher than IQR. Okay.
Right.
These are relatively minor changes this year after a pretty good overhaul last year. They're going to amend the regulatory definition of the reporting period to be a continuous 180 days. That's not different. They've made that change previously back in 2024 from a 90-day period, but they're finally actually putting it in the regulation. They're modifying the security risk analysis measure to now require hospitals and critical access hospitals to attest yes to conducting a security risk management. That's in addition to the current requirement that you attest to having conduct a security risk analysis. I should have noted at the top that one thing about PI is that it is also applicable to critical access hospitals, for if they fail to report on PI, they go down from 101 to 100% of costs in their reimbursement. So do pay attention for our critical access hospitals here.
And Martie, that 0.8 is what their update will be.
Like that. So it's reduced down to that.
Yeah.
So if they report IQR but not PI, part of the issue here is, and we've delved into this, for PI and IQR have started to overlap because of the ECQMs. And so if you're a provider that doesn't have, if you're a hospital that doesn't have the capacity to report on ECQMs, you're going to get hit coming and going because you won't hit the IQR requirements and you won't hit the promoting interoperability requirements because they're both now linked through the last set of rulemaking. Also for PI, they're going to modify the SAFER guides to require hospitals to attest yes to completing an annual self-assessment using the SAFER guides that were published in January of 2025. And they're adding an additional bonus measure so you can gain additional points on your PI score for public health and clinical data exchange using the Trusted Exchange Framework for Common Agreement. Let's go to the value-based purchasing programs. As you know, these have been around now for more than a decade. There are three of them: the Readmission Reduction Program, the Hospital Value-Based Purchasing Program, and the Hospital Acquired Condition, or my all-time favorite acronym, HAC. That program as well. So Hospital Readmission Reduction Program, this is where if you fail, it's actually no reporting on your side because CMS actually calculates all the data from its records. But if you have a higher than expected 30-day readmission rate, you are penalized up to 3% on your base Medicare inpatient payments, which can indeed be significant if you're on that 3% side. There are several proposed changes this year. They're going to refine all 6 readmission measures to add MA patients to the cohort. So adding them, again, considering the readmission rate around our Medicare Advantage patients, that will begin with the 2027 program year, meaning they're going to start looking at the data here in 2025. And they will also modify the formula they use to calculate the aggregate payments for excess readmissions. That's how they determine up to 3%. So if it's a 1.2 versus a 1.6, that's based on this calculation of aggregate payment for excess readmissions. They're going to reduce the applicable time period for measurement from 3 years to 2 years, again, because they'll have more patients in the denominator going forward. They're removing COVID-19 diagnosed patient measure denominator exclusions from all of those 6 readmission measures. So as we discussed previously, we're no longer going to take those patients out in calculating readmission rates. And once again, updating that extreme circumstances exception, again, to allow a extension of time in which to report as opposed to simply being excused for the program altogether. In the Hospital Value-Based Purchasing Program, this is where CMS withholds from everybody 2% of their payments. And then based on hospital scores on these measures within the value-based purchasing program, they redistribute the money among the hospitals. There are 14 measures in this program currently, which go across 4 domains. Proposed changes this year is modifying the measure that related to hip and knee complications beginning in the 2033 program year. So it's a way off yet, but to include Medicare Advantage patients in the cohort. The delay is statutory because you have to have a measure first in the IQR before you can put it in the value-based purchasing program. They're removing, again, the COVID-19 exclusion from the denominator. They are removing the health equity adjustment for hospitals that serve a higher percentage of dual eligibles. This was added during the Biden administration. It was intended to up the score for those hospitals that are serving a more low-income, higher-risk population. They are removing that beginning this year and saying that their purpose is to simplify the scoring methodology by removing the adjustment. It will help folks better understand the program with clearer direction so they can pursue the incentives created by the submission. I'll leave it there. They once again, as they do every year, provide previously and newly established performance standards through federal fiscal year 2031. And again, that update to the extreme circumstances exception to allow for extension of submission deadlines rather than excusing from the program. The HAC program, very few changes this year. This is the program where if you're in the top quartile, having the highest number of infections, hospital-acquired conditions, you're going to see a 1% reduction in your payments. There's no changes to any of the measures other than some technical updates to the hospital-acquired infection measures from the CDC. And they'll be implementing those changes around the standard population data. Way over my head, tried to read it, but they're doing some changes to the measures. And then again, the extreme circumstances modification for this program as well. Finally, the last pages of the inpatient rule concern team. It's how many pages?
87. 87.
87 pages of technical changes to TEAM. TEAM, as you'll recall, is the Transforming Episode Accountability Model. This is the mandatory episodic payment model that hospitals have been selected to participate in. Many of the hospitals that had been selected had their fingers crossed that when we published the proposed inpatient rule that CMS would decide to significantly reduce the number of hospitals participating in this mandatory model. That wasn't necessarily a pipe dream, because back in 2017, the Trump administration reduced the number of hospitals participating in the Comprehensive Care for Joint Replacement, which was the first mandatory payment model that had been introduced by the Obama administration. But it appears that CMS is eager to realize the savings from mandatory episodic payment models. And instead of making significant changes regarding participation or risk levels, they instead have 12 very technical changes to the rule. Rather than boring you with these details, we've included in the handout section, handout pane on the webinar, a copy of the article we published yesterday that details those changes for those hospitals that will find themselves participating in TEAM beginning on January 1. Again, other TEAM resources also available on our website for folks. Kathy, let's talk about SNFs.
Sure. We've got the same day that we got the inpatient rule, we got the SNF rule. Again, comments are due on June 10th. Just in terms of the payment update, we're looking at a proposed 2.8% increase in the SNF market in the SNF program. The update that they got in 2025 was 4.2%. One thing I want to call your attention to is that in these calculation under legislation, as it relates to the skilled nursing prospective payment system, they have built in to the system an adjustment when the market basket forecast is not accurate. And if there's an error in the forecast, they have actually said, we can go back and fix it the next year. What we're looking at is in the calculation of the market basket or the overall rate, we're looking at a market basket of 3% plus 0.6 for forecast error and then less the productivity. So some way or other at some point, it would be very nice if we could get something built into inpatient, psych, rehab, et cetera, outpatient, a forecast error. because if they're off on the increases in expenditures, then it would be nice to be able to fix it from one year to the next.
Wouldn't that be nice to have the Congressional Budget Office do a study and show how much more hospitals would have been paid had there been such a provision?
Exactly. But, when, it's interesting that it's in the skilled nursing program, but not in any of the other prospective payment systems. Another provision that they are making under the skilled nursing program is the code mapping for the patient-driven payment model, the PDPM. They are starting to make some modifications there to keep things consistent with coding guidance from ICD-10. Martie?
Updates to the quality reporting program. They reversed the inclusion of new standardized. There were 4 new elements in the standardized patient assessment that had been added last year. They took them out. They all related to social determinants of health. There are other SDOH elements in the assessment. Those stayed, but the ones added last year go away. They are amending the reconsideration policy and process to afford greater time for providers to challenge data. And they are seeking input from SNFs regarding future measures in certain areas to be added to the program, revising some data submission deadlines, and I think, again, a theme we heard in the inpatient rule, advancing digital quality through the use of FIR in the quality reporting programs. Also, there's a lengthy request for information to SNFs regarding the current status of current usage of health IT within those facilities. On the SNF value-based purchasing program, they are, again, removing the health equity adjustment that benefits SNFs that serve a higher portion of dual eligibles. Same explanation that they offered in the IQR, in the hospital value-based purchasing program. They are doing some application of scoring methodology. They're adopting, again, a reconsideration process that allows for appeals of decisions before data is made public. And as always, they provide the estimated performance standard going forward several years. Kathy, briefly here.
Yes, if you are a skilled nursing facility, if you are licensed as a skilled nursing facility, please remember that May 1 is the deadline for you to complete the 855 SNF attachment, where you are basically disclosing information on additional disclosable parties. And these are people who you work with. They are individuals who or entities that exercise operational, financial, and managerial control over the skilled nursing facility, or provide the facility with policies and procedures, financial or accounting services, any management or administrative services, or management or clinical consulting services. You're going to have to provide detailed information on this 855 attachment. If you have not done this, recognize May 1 coming very quickly.
Oops.
Okay, let's move on to psych. And the inpatient psych rule, again, last Friday, comments due June 10th. We are looking at a 2.4% increase in the rates based upon 2021 data. That they have said that they will use more current data in the final rule if it becomes available. The labor share, they are increasing slightly from 78.8% to 78.9%. For those of you who are in either teaching programs, have teaching programs, or are in a rural location, I urge you to comment on this rule, because they are looking to increase the facility level adjustments for both teaching status and rural location. A small increase related to the rural location, but teaching status significant. So I urge you to take a look at this and to comment on that rule.
Oops. Okay, Kathy, we're fighting over each other.
I know.
Okay.
Yeah.
Just on the quality reporting program for these facilities, removing the same 4 measures they removed from the hospital inpatient program, those around health equity, as well as the COVID vaccine COVID vaccine rate among healthcare personnel. They are making some adjustments to psychiatric facility discharge, readmissions. Again, the extreme extraordinary circumstances policy, and seeking feedback, again, from inpatient psychiatric facilities and the use of technology within those facilities.
In the again, the next rule we received was inpatient rehab, and we are looking at a payment rate update of about 2.6%. Compared to the 3% that we received in 2025. They are looking to decrease the outlier threshold from about $12,000 to close to $12,000, a moderate decrease, but $12,043 to $11,971. So a slight decrease in the outlier threshold.
So quality measures for inpatient rehab track the quality program for skilled nursing facilities. But there's one change made in the rehab program that is not made in the skilled nursing program, which is the removal of the measures regarding vaccination among healthcare personnel and the percentage of patients or residents who are up to date on their COVID vaccines. Those two measures exist in the SNF quality reporting program, but they were not removed. So they are removed from the inpatient rehab facility. Otherwise, these are the same changes you'd see in the SNF quality reporting program.
Hospice published again, same date, same time, comments due June 10th. So y'all got a lot of letters to write. They are proposing a 2.4% increase for the hospice programs. This is essentially tied to the inpatient market basket, less productivity. I've given you on the slide the rates for 2026 that are being proposed and what the current rates are. They are looking at increasing the hospice cap by close to $1,000. Again, this is the average overall expenditure for your patients. There was also a policy clarification included in the final rule saying that a physician member any physician member of the interdisciplinary group taking care of the patient can recommend admission to hospice. This keeps it consistent with the current conditions of participation and certification regulations. Previously, the rules had said that only the medical director or a physician designee could recommend admission. And then they have also clarified that hospice face-to-face encounter attestation must include the physician's signature and date, making that clarified in the rule.
Changes to the quality program is mainly directives to hospice regarding the new hospice outcome patient evaluation, the HOPE instrument, and the new database through which they'll submit information. So just again, highlighting that for hospice providers. This brings us to our last polling question. So Jennifer, to you.
Don't go away because we've got one more big issue.
Our final question is, does your organization intend to respond to the deregulation RFI and/or comment on any of the proposed rules? 1, respond to RFI and comment on proposed rules. 2, respond to RFI only. 3, comment on proposed rules only. 4, neither respond to RFI or comment on proposed rules. And 5, unsure at this time. You must fill out the polling questions in order to receive CPE credit. You will have 30 seconds to answer.
What can we do to convince you to comment? At least on the dereg RFI, Kathy, as we referenced way too many times now, April 30, we're doing deregulation or RAMA. Kathy and I have started our list of potential targets for deregulation, as well as some dangerous targets for deregulation. Sort of how do you balance patient health and safety, program efficiency against administrative burden? It's a very, very challenging task. And we'll go into greater detail on those regulations as well as the comment process.
And remember that we can't ask them to eliminate something that is required by statute, because my mind immediately went to the SNF 3-day rule.
Nope, can't do it.
Can't do it.
Yeah. Okay.
Thank you for participating in our poll. Back to Kathy and Martie.
Thank you. Looking very quickly at an April 15th, let's go to
That was yesterday.
Okay, so on our calendar, the executive order that came out related to lowering drug prices by once again putting Americans first. In a recent webinar, Martie and I talked about some of the things that we are concerned that might happen from a way to reduce overall spending, and we're starting to see them come to light. First of all, requirement that within 180 days, the Secretary published in the Federal Register a plan for conducting a survey to address your hospital acquisition costs for outpatient drugs. Remember that under the 340B payment reduction litigation that happened a couple of years ago, the reason that it was CMS was found in fault was because they had not conducted a survey to actually establish what the acquisition costs were. Well, now they are going to be publishing a rule where they plan to conduct a survey. Feeling that could even be in the outpatient rule that comes out in the next couple of months. They are also required to take action to ensure future grants available under Section 330E, which is the Federally Qualified Health Centers, are conditioned upon health centers establishing practices to make insulin and injectable epinephrine available at or below the discounted price paid by the health center. And then they are requiring to, within 180 days, propose regulations to ensure that payment within the Medicare program is not encouraging a shift in drug administration volume away from less costly physician offices to more expensive hospital outpatient departments. Did we talk about site-neutral payments? Because that's exactly what they're doing there. Finally, the Secretary shall take appropriate steps to develop and implement a rulemaking plan and select for testing a new payment model to improve the ability of Medicare to obtain better value for high-cost prescription drugs.
Which includes Part B drugs.
Yeah.
Part D, yeah.
And so this is going to wind up, we're starting to look at things that we might be taking off of the congressional list of things to cut, because on the list that was developed by the House previously, we had the issue of reducing payments for 340B drugs. We had the issue related to drug administration off campus. So what's going to happen here? And actually, if you read this particular requirement related to drug administration, it is hospital outpatient departments, not necessarily even off campus departments. So
there's a lot more in this executive order around PBMs and drug importation from Canada and the pricing on pills versus biologics and all of that. But these are just the highlights that are going to directly impact providers, we believe. We made it to the end. So thanks to everyone for participating. We hopefully will see you back on April 31.
April 30.
Oh, there is no April 31. I give up. Okay. So Jennifer, back to you. Take us home.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions or if we can help, please contact us at pyapc.com. Thank you again for joining us and have a great rest of your day.